Hello, it's Dr. YouTube here, where I upload educational medical videos on a regular basis. Today's talk will be all about adrenal insufficiency, everything you want to know about, including Addison's disease. The outline of my talk will start with a brief overview of adrenal insufficiency, and followed by that an actual case that I encountered and diagnosed and managed. Let's start. Adrenal insufficiency. What is it? Let's start with basic physiology. You've got your hypothalamus, which secretes CRH, corticotropin releasing hormone. This stimulates the pituitary gland, the anterior pituitary gland, to produce ACTH. The ACTH stimulates the adrenal glands to produce cortisol. The cortisol has a negative feedback up in the brain. So for example, the more cortisol that you produce, the less CRH and consequently ACTH that is produced. There are adrenal insufficiency can be divided into two causes: primary, where primarily the adrenal glands aren't working for various reasons, or secondary, reasons beyond the adrenal glands, for example, the brain. So let's start with primary adrenal causes. It could be an autoimmune condition, such as Addison's disease, where the body attacks the adrenal gland itself, so it stops secreting cortisol. You can also have hemorrhage cause, for example, bleeding, if they're on warfarin, or novel anticoagulants. Can also be due to infection, such as tuberculosis, or neoplastic causes, such as bilateral adrenal metastasis in cancer. We're seeing more and more of chemo drugs causing adrenalitis, which I'll go through in a bit. As I said, secondary causes are basically causes beyond that, not due to adrenals. So for example, due to the brain. For example, if you've got hypopituitarism, where the brain doesn't secrete CRH and ACTH, then your adrenal glands won't be producing cortisol. So that's a secondary cause. What would the blood test show? Well, the blood test would show low sodium, high potassium, and that would occur because of low aldosterone. Okay, low aldosterone. Glucose would be low, urea tends to be high, and so is calcium and eosinophilia. There's an SIADH, or syndrome of inappropriate diuretic hormone picture, with elevated urine sodium and elevated urine osmolality. What are the signs and symptoms of adrenal insufficiency? It really is a chameleon. Can present with all sorts: weight loss, anorexia, nausea, vomiting, diarrhea, abdominal pain. Clinically, particularly with adrenal insufficiency, there is postural hypotension, pigmentation, especially in Addison's disease, and vitiligo, because it's an autoimmune cause. The management: steroids, steroids, and steroids. If the patient is unwell, give them intravenous 100 milligrams of hydrocortisone stat, followed by either 50 milligrams every 6 hours, or through an intravenous infusion, 200 milligrams over 24 hours. You want to make sure the fluid hydrated as well with normal saline, and once they're a bit well, you can step them to oral hydrocortisone, and also fludrocortisone for blood pressure support. So let's start with a case. It's an actual case. I was involved recently. 60-year-old lady, back pain, leg weakness, history of breast cancer and type 1 diabetes. So note the autoimmune cause here. Someone does an MRI spine because, well, you've got someone with back pain, previous history of cancer, you want to rule out anything sinister. involving the back to rule out cardiac equina, which was absent in this case. You do an ECG. What does this show? Tall tinted T waves, broad QRS, diagnosis, hyperkalemia. And indeed, the blood test does suggest this. Potassium 7.9 and sodium of hyponatremia low, 128. So remember, low sodium, high potassium in adrenal insufficiency. But note that it can be normal in adrenal insufficiency too. Note the high calcium as well, because most of them are dehydrated. So you perform a short synaptin test. The logic for doing this is synaptin contains ACTH, which stimulates the adrenal gland. So if the adrenal gland isn't working, for example, adrenal insufficiency, in spite of ACTH that you give them, the adrenal glands don't produce cortisol. So cortisol levels will be low, as seen here, less than 450. Remember, if the adrenal glands aren't working, there's that negative feedback. Cortisol isn't produced. So if we go from the first slide, there's no cortisol being produced. So there's that negative feedback, which stimulates the brain up there to produce ACTH. So ACTH will be high, as seen in this case. Renin is high and aldosterone is low, because remember, aldosterone is produced by the adrenal glands. So in primary adrenal insufficiency, all the three hormones, salt, aldosterone, sugar, glucocorticoid, and sex hormones aren't being produced. So aldosterone levels will be low. And renin is high as a result. Because it's an autoimmune condition, adrenal cortex antibody will be positive in many cases. The treatment, as I said, we started her on, well, first of all, we suspected it was adrenal insufficiency. The blood test confirmed primary Addison's disease. So we treat with IV steroids initially, as we said before, and discharge with oral hydrocortisone and fluorocortisone. And lo and behold, the U's and E's pretty much normalize. So why is it important? Adrenal insufficiency is a life-threatening condition. People can die with it, as you can see here. Cases being missed. This is a report from a coroner, basically detailing cause of death and learning points. As you can see here, cause of death, Addisonian crisis, due to undiagnosed Addison's disease. This is a real case. How did he or she present? Difficulty in eating, weight loss, anxiety. And later, love of salty food, tanning easily, nausea, vomiting. So those are important points to be aware of. If you're seeing a generally vague patient, think about Addison's or adrenal insufficiency. So, learning point, adrenal insufficiency crisis is an endocrine emergency. Treat with steroids. In the outpatient clinic, it's all about promoting knowledge, preventing adrenal crisis in the diagnosed adrenal insufficient patients. So it's all about sick day rules. So telling a patient to double the steroids whilst they're unwell. For example, if they're taking 10-5-5 of hydrocortisone, you tell them to take 20-10-10 for 3 days if they're unwell. You also give them injection kits, the hydrocortisone 100 milligrams, so that they can self-inject if they're unable to tolerate oral steroids. And they should call for medical, they should also seek medical attention following injection of this. We also inform these patients to wear medical alert bracelets. So we briefly talked about the anti-cancer drugs causing adrenalitis. How does it do it? Well, the ones, especially the MABs, nivolumab, pembrolizumab, they enhance T-cell activity against antigens of tumor and normal cells. So you get basically antibodies against normal tissues, and therefore you get adrenalitis, causing primary adrenal insufficiency. And also it can cause other itis, so hypophysitis in pituitary gland, thyroiditis in the thyroid gland. So learning points. Think about adrenal insufficiency in your unwell patients. And always call your friendly endocrinologist. I hope you've found this video helpful. If you do, please give it a thumbs up and have a good day. Take your steroids, everyone.